Welcome to SDHC's Health and Wellbeing podcast. Before we begin, we want to emphasise that the information shared in this podcast is for educational and informational purposes only. While we strive to provide accurate and up-to-date content, it is not a substitute for professional medical advice, diagnosis or treatment. Always seek the guidance of your doctor or other qualified healthcare provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have heard on this podcast. Remember, your health and well-being are invaluable, so prioritise consulting with a medical professional for your personalised care. Hi everybody, you're listening to the Health and Wellbeing podcast from Hillbrow Health and Wellbeing and SDHC with your host, Dr Nick Harvey. The purpose of this show is to help people understand how they can help themselves and others with their health and well-being. Every episode, I interview an everyday expert to understand the latest evidence and advice on how to improve your own health or help others. This month, I'm excited to welcome Saul Rajak. Together, we'll explore a vital topic, eye health essentials, understanding thyroid eye disease, cataracts and blepharoplasty. Welcome.
Thank you, Nick.
So Professor Rajak is an ophthalmic and eyelid surgeon who practices at the Nuffield Health Brighton Hospital. He's also an NHS consultant at the Sussex Eye Hospital and Brighton and Sussex University Hospital, and an honorary senior lecturer at Brighton and Sussex Medical School. Prof Rajak performs around 400 eyelid plastic surgery procedures every year, including upper and lower lid blepharoplasty, tumour excision surgery, eyelid malposition, tear duct surgery, orbital surgery, and around 200 cataract surgeries. He's internationally renowned for his surgical training website. He also consults in general ophthalmology, including glaucoma and emergency eye conditions. Prof Rajak qualified from Nottingham University in 2000. He trained in ophthalmology in the South East, including at Moorfields Eye Hospital, St Thomas Hospital, the Sussex Eye Hospital, and then completed advanced fellowships in oculoplastic, that's eyelid, orbital, that's eye socket, and lacrimal, that's tear drainage surgery at the Sussex Eye Hospital, and a world-renowned fellowship at Adelaide University. He researched the management of trachoma in Ethiopia for 3 years and was awarded his PhD for this work. He continues to research, write about and present at national and international conferences on oculoplastic surgery. So welcome, and thanks for that bio. I'm exhausted reading it. Tell me a little bit more about your journey and to where you are today.
Thanks, Nick. Probably just as exhausted hearing it, to be honest. But yeah, I mean, I think everything in life is often a happy accident when it goes well. And I guess the happy accident for me is having loved medicine and then falling upon ophthalmology or eye surgery and finding it equally stimulating and enjoyable. And then everything else has been an exploration of things that have been interesting, fun. I've always loved to travel. So the 3 years in Ethiopia was part of a desire to see the world and combine it with work. It was absolutely wonderful, mainly with hindsight, but probably at the time as well. And similarly, Australia was a chance to go to an extraordinary pioneering centre of eye surgery, eye socket surgery, and again to go off with my family and my at the time young kids to spend 2 years living in Australia. So, and I continue to have the same desire the same curiosity, the same desire to find out more and learn more and explore more. And I've probably worked out now that I'm never going to own a super yacht, so I may as well do the things that I enjoy, and which is finding out more about eyes.
Thanks. Yeah, it's interesting that I've done a lot of reflecting lately, as well as there's a money doesn't buy experiences, does it? And happiness.
No, and you don't take any of it with you, so you may as well have fun and explore and have a journey along the way. And I guess if I'm honest now, it's what I want my kids to grow up with is exploring the world and not trying to make more money.
Yeah. And how are you managing that juggle then between that family and work life? Because I sense you're nearly equally passionate about both.
It depends who you ask, whether you ask me or my family. I think my family would say I don't manage it very well and I'm not home nearly enough, which is probably true. I would say I try to be as efficient as possible and spend quite a lot of time on a tennis court with one of my daughters, which is definitely good quality family time, at least for two of us. And I do genuinely enjoy being at home and hanging out with my wife and kids. And I guess life sometimes is all about the holidays as well, when you really get to spend time with your family.
Yeah, great. Thank you for sharing that. I think it's really helpful for patients and the general public to understand that we're real people too. So to jump into the topic, I think the first one we were going to talk about was thyroid eye disease. And I know it can cause a lot of discomfort and changes to vision, but I'll let you talk about that and help us understand a little bit more what we should know about both in the general practice community, but also patients who have concerns.
Thanks, Nick. Yeah, I mean, it's my passion, and you cut me off at any time if I start to get boring, because I could probably burble on for the whole podcast about thyroid eye disease, but it's this kind of extraordinary disease. So I think most people will have heard of or know someone or even have a thyroid problem, either an overactive thyroid can make you feel a bit hot, sweaty, lose weight, a bit agitated, anxious, or an underactive thyroid, which does the opposite, make you feel a bit lethargic, gain weight. And so many people, something like well over 1 million people in the UK will be on some sort of thyroid treatment, normally with their GP and not requiring specialist care. But a proportion of them, and actually probably quite a high proportion of them, will have thyroid eye disease as well. And they kind of seem like odd bedfellows. Your thyroid gland is in your neck and is the kind of thermostat for your whole body. And then your eyes are obviously in your head and seem to have nothing to do with your thyroid gland. But there's this strange connection where the reason that a lot of people have an over or an underactive thyroid is because they have these circulating antibodies or little inflammatory particles that are landing on the thyroid gland and either stimulating it to overproduce thyroid hormones or blocking it to underproduce. And the odd thing is that those antibodies also land in and around the eye, so in the eye socket, in your eyelids. And obviously there's no thyroid tissue in an eye socket, so they're not going to produce thyroid hormones, but they still cause inflammation. So inflammation means things get hot and red and swollen and puffy. So these little antibodies probably have sort of landing points or docking points in the eyelid tissues. Why they only land in the thyroid gland and the eyelids and eye sockets, we don't know. Why don't they make your knees swollen, your ankles swollen? Not a clue. And they cause everything to swell up in the minor, sort of milder way, which is probably affecting quite a lot of people with thyroid dysfunction. They might cause slightly dry eyes, slightly gritty eyes, slightly red eyes, slightly uncomfortable eyes. And you might just think, well, maybe it's hay fever, maybe they're a bit irritated by the environment or something. And then when it gets severe, you may well have seen pictures of people with these very, very prominent sticking out eyes. The kind of Marty Feldman look is the classic description. And that can be debilitating. Obviously, it's hugely uncomfortable, but if there's huge amounts of swelling and pressure behind the eye, then you're going to start to get pressure on the nerve behind the eye, which will affect your vision, affect how your eyes move, so you get double vision, and may need emergency treatment. So that's a long-winded description of what goes on.
It's a worrying place to end in the emergent treatment. I mean, in terms of those 1 million people with thyroid problems, what sort of proportion are we talking about will have some eye disease, and what sort of proportion need to have an intervention? Yeah,
it's a good question, because I don't think we know the answer. It may be as many as sort of 10 or 20% if you actually ask those patients, and we fail, I think, as doctors often to ask, do you have red, gritty, uncomfortable eyes? Patients will say, yeah, but I just thought it's kind of one of those things. And it's probably a sensible thing to ask, because there's actually very straightforward, simple, conservative, safe interventions or therapies or treatments to help that. So really simple things, just dry eye drops or artificial tear drops used regularly will make eyes that are dry and gritty much more comfortable. Blinking regularly and deliberately. Wearing most people who've got dry, gritty eyes will know that when they wear sunglasses or wraparound glasses, they're more comfortable because they're slightly protected from the environment. And then there's increasing evidence now for selenium and vitamin D as two supplements. And we've all got a bit of a love-hate relationship with supplements because we don't quite know what does work and what doesn't work and whether we should be taking everything or nothing. But certainly there's been a big trial that shows that selenium supplementation, which can either be with just diet, so Brazil nuts classically, prawns if you like them, but otherwise selenium supplementation. And so selenium, certainly there's evidence that it reduces the severity of thyroid eye disease, and even probably in the milder stages. And similarly, vitamin D, a bit more contentious, definitely good for most of us who don't get enough sunlight exposure. but and certainly involved in thyroid function and probably the health of eyes in thyroid disease, but probably not a bad thing for most people to do so again, vitamin D through supplementation typically, or I guess running around naked in your garden is the other option, but I think I'd probably go for supplements in the middle of winter in the UK. So.
Yeah, and I think, and on a general point, I think these days we're recommending vitamin D supplementation at least October to April in the majority of the population, and almost more. We should find a reason not to, rather than
absolutely, and that chimes perfectly with the sort of million people with thyroid dysfunction.
I'm interested with the selenium question then. Should somebody without eye symptoms take it because that might be preventative, or did the trial not look at that?
It didn't look at it, and the trial, it was a very robust trial, which was published in the New England Journal of Medicine, which a few people will know is the kind of biggie of medical journals. So it's a proper trial. But it also, unfortunately, as with all these trials, it asks as many questions as it answers. And so we don't know even which populations it was done in. I think the trial was done in Central Europe, so Germany. So we don't know, if other populations have different selenium diets. We don't know about severity of thyroid eye disease, and we don't even know with people who don't have it. So I guess the bigger question is it 100% safe? And the answer with everything is no. There are some suggestions that there are groups who have slightly higher risks of other diseases with overdosing on selenium. So I think I'd always do these things with a slight sense of caution and not just go for it with everything. But yes, I think if you have thyroid dysfunction, and certainly if you have any sense of thyroid eye issues, you probably should be taking selenium supplementation or selenium increases in your diet.
Mm-hmm. Thank you. That's a new one for me, so that's really useful. And just to explore then, so we've got very mild thyroid eye disease, which is very common and mainly treated symptomatically with symptoms and eye drops. And I think GPs, if you don't disagree, are fine with doing that.
Definitely.
But then we've got the moderate and the severe eye disease where the eye's looking to extrude a little bit. The lids maybe don't cover the iris. Is that right?
Correct.
And what do we do there?
That's where the problem is. Actually, the strangely, the easiest groups are the milder ones. And as you say, GPs definitely should be managing them and asking about it. And the severe ones, because you need emergency treatment, which is either immunosuppression, so typically steroids or other immune suppressing drugs to suppress those antibodies that I mentioned earlier, so try and reduce the inflammation, or sometimes surgery to try and make the eye socket, actually, it sounds kind of rather brutal, but it's actually very effective surgery to try and enlarge the eye socket so there's more space for these very big swollen muscles and fatty tissues in the eye socket. And that's one of the things I do, and we do lots of at the Sussex Eye Hospital is orbital decompression surgery, or surgery to enlarge the eye socket. So that's great. It's obviously severe. It's obviously emergency treatment. But then there's this huge moderate group in the middle where we don't have a very satisfactory treatment. We don't have an ibuprofen equivalent of saying, well, this is how we treat it a bit. And unfortunately for those, we're always making a decision. Is it severe enough to take steroids or some other immune suppressing drug? Or is it mild enough that we can say, okay, sit tight and it will probably settle down in due course? Because bizarrely, unlike almost every other autoimmune or inflammatory disease, thyroid eye disease calms down. Not thyroid dysfunction, but thyroid eye disease. So you normally have to sit it out for 6, 9, 12 months, and at some point it will calm down and settle down. Other things, and they're milder things. There's a very interesting relationship between smoking and thyroid eye disease. I mean, obviously you all know that smoking's bad for us in every which way, and I won't labour the point because it's been laboured many times before, but there's a peculiar connection between smoking where it specifically worsens or exacerbates thyroid eye disease. And so it's absolutely the first thing that people need to do if they do smoke and have thyroid dysfunction is stop smoking, because it will make your eyes significantly worse. I am asked now in the modern world again and again is, can you vape? And the answer is, we have absolutely no idea. We don't know which chemicals in cigarettes are the ones that stimulate excessive fatty swelling in the eye socket, and we don't know if those are the ones that are in vapes or not. If it's the nicotine, we're in trouble because that's probably in vapes, I assume. If it's the tar, then it's fine because that's the bit that's been taken out of cigarettes. And time will tell whether vapes have the same stimulating effect.
Thank you. Yeah. If I was a betting man, I wouldn't be vaping either.
No. I suspect we'll find out in due course that they're not so good either.
Yeah. Yeah. Fascinating. Thank you. So at the severe end of the spectrum, I guess, just thinking about people thinking, oh God, have I got severe thyroid eye disease? So what are the signs of that so that actually I've got some time?
Yeah, good question. And it can happen rather subtly, moving slowly from mild to moderate to severe. So it's really worth knowing what they are. So the things that you start to look out for is your eye sockets or your eye behind your eyes feeling tight. So that might give you a sort of achy sensation, or might start to give you double vision when you look off to the extreme. So far left, far right, up and down. You might just feel, or you might think that people might say you look surprised a bit as your eyelids start to retract. So your upper lids go up a bit and it gives a slightly startled look. It may not be dramatic. It might just be with expression that they just look slightly overly open. You might start to feel that your eyes are more and more dry, particularly if you go out in cold and windy conditions, and then they can fluctuate quite wildly between dry and then sudden pooling of tears. And then vision loss is often very gradual in thyroid eye disease, so is sometimes not noticed, particularly if you've got other eye problems like cataracts. You really might not notice it. But one of the earliest signs is a change in colour vision. So if you start to notice, if you happen to have a colour vision chart, and obviously everyone can now with Google, you can just look one up. But if you don't have that, if you start to wonder whether colours are just slightly muted to where they were, then it's certainly worth getting checked out.
It's an interesting one because I've got experience from that being an early sign in other problems too, and we often don't clock onto that, do we?
Yeah, absolutely right. So, and the reason it's an early sign, a similar early sign, is any pressure on the optic nerve, which is the big nerve cable coming out of the back of the eye that ultimately gives us our vision. Any pressure on that will, of course, end up with you losing vision if it's significant pressure for a long period of time, but the early pressure gives you subtle changes in colour vision, and you can get pressure from thyroid eye disease, but you can get it from a whole lot of other things as well. And so you're absolutely right. It's an early sign to look out for, and it's an early sign that's quite often missed. And it's perhaps not surprising that we miss it. We probably don't notice as patients if the colour is slightly changing over a long period of time. And as doctors, we probably don't ask about it enough or test it routinely enough to find out.
Thank you. We could talk for hours about thyroid eye disease, but you've got so much more to talk about. I think next on our list was to discuss a little bit about the under eye bags and droopy eyelids. Now, this is super common, isn't it?
Yeah, well, we've gone full circle from blinding eye disease and pressure behind the eye and debilitating autoimmune diseases to bags under the eyes. Yeah, they're really common, and I see a lot of it. And so sort of excess skin above the eyes, which is common with time and age, and then drooping eyelids, which is just the actual bit that the eyelashes are attached just underneath the fold of skin, and then bulges and bags and excess skin in the lower lids, and it ranges from everything from being genuinely a sight affecting condition as the upper lids or the skin of the upper lids droops down and starts to encroach into your visual field, and you start to realize that you're not seeing things higher up or banging into higher cupboard doors, or if you're a plane spotter, you might notice it a little bit earlier, to being a cosmetic condition, which is fine. You know, it's people will notice the moment that they look in the mirror and they go, I've had a good night's sleep and I still look tired, and that doesn't seem fair. And that's when they might start thinking about something to address it.
And yeah, so it covers a whole range of interventions here, really, isn't it? What are the non-surgical treatments for some of these that we should be thinking about?
So there's the kind of, most people have done them. If they start to look in the mirror and they look tired, then they'll try and increase their hydration, maybe try and increase their exercise, try and increase their sleep. But the disappointing thing is if you do all of those things and you wake up and people still say you look tired, but they're certainly worth doing. It's quite creative. I don't think they work particularly well from what people have said. There are little bits of tape for the upper lid that hold the skin back, which is quite clever. And I think they can work for a while, but I think they've got a limited scope for holding back skin. And then there are various high street cosmetic things of trying to laser and all sorts of newfangled treatments which have variable efficacy and potentially have risks as well. So I've got mixed feelings about them. I don't think they're as specific or targeted or even precise as they probably should be for such a cosmetically aware, apparent place.
So what are the risks of the sort of procedures that you do, and what are the things people should be thinking of? I'm thinking also particularly now is, I think there's probably a bit of tourism to some other countries for these kind of operations.
You're not asking for a friend. So yeah, there is definitely, this is a big one with medical tourism, and we see the consequences. I think so. There's two very different things. So upper lid blepharoplasty, removing the upper lid skin, or upper lid ptosis, which is elevating a slightly droopy lid, is a relatively safe procedure. No surgical intervention is 100% safe, obviously, and that's real. You know, you can get rare but significant infections from procedures. You can end up with eyelids that don't completely close. Again, incredibly rare with upper lid surgery, but it is a risk. And whenever you go into a procedure, you've got to take those, 1 in a few thousand risks seriously and reflect on them properly. But removing some upper lid skin, which is called a blepharoplasty, or elevating an eyelid, which is ptosis correction, is a pretty safe operation, done almost always under local anaesthetic, so you're awake, and you walk into a minor operations theatre and you walk out an hour later. Whether it will be cosmetically 100% or 99% or 95% is another question entirely, but I think overall it's a pretty safe procedure. Lower lid surgery is very different. So if you're trying to remove lower lid bags, those bags are actually fatty tissue, normal fatty tissue, so not excessive fatty tissue from the eye socket that is bulging forward. So I'm going to bore you with anatomy for a second, Nick, but there's a layer called the septum, which restrains all of our eye socket fat. And as we get older, and it happens at different speeds in different people, that septal layer, that septal tight drum skin-like layer that holds the fat back gets weaker, and so the bulges of fat can come forward. And as a result, when you're doing lower lid blepharoplasty or eye bag surgery, you're actually going to the front of the eye socket to reduce that fat and restrain it and hold it back. And so that's almost always a general anaesthetic operation. It's a bigger operation, not a huge operation, and because you're operating just at the front of the eye socket now, not just on a skin layer, you are taking greater risks. So again, they're rare, but now the risks suddenly include visual loss. So there's, probably a 1 in a few thousand risk of losing sight when you operate in that area. There's a risk of double vision because there's muscles that control the eye near where you're removing the fat. And there's a greater risk of the eyelid being significantly malpositioned from the surgery. So down or outwards after the surgery. Having said all of that, that's the nature of surgery, and once the risks and benefits have been weighed up, it can still be a hugely effective and rewarding operation, both for patient and surgeon. So.
Thank you. Thanks very much. So on to something bit more, I was going to say a bit more interesting, but maybe not, bit more NHS. Yeah. It's cataracts. Yeah. I think everyone probably knows somebody who's had a cataract done.
Yeah, I think it's still the commonest operation in the UK and possibly the world, but I'm not sure. Shall I tell you what a cataract is first? We start at the beginning. So we have, obviously an eyeball has parts within it. Towards the front of it is a part called the lens, which, like lenses do, focuses light. And the reason it focuses light is the light needs to land on your retina. And as we get older, that lens goes slowly from being absolutely crystal clear when we are young and gradually becomes cloudy. And so the data is a bit imprecise, but something like 60%, so nearly 2/3 of people over the age of 70 will have cloudy enough lenses to call it a cataract. And at some point, and that is variable from patient to patient, person to person, you will decide with your optician and then your ophthalmologist or your eye surgeon that it's time to remove that lens or that cataract because it's a cloudy lens now. The exact timing is really interesting and very patient specific. So to give you some slightly ridiculous examples, if you're a fighter pilot or a professional cricketer, you might get in there quite early because your career is going to come to a grinding halt even if it's slightly affected. If your whole aim is to listen to the radio in the dark, then there's probably not any point in taking any risks at any point, and you can let the cataracts progress because it's not unsafe to let them progress. It obviously just affects your vision. But certainly we're not in the era of 30, 40 years ago where we had to wait until they were ripe. We can now, the surgery is equally doable when they're early cataracts or later cataracts. So we'll generally gauge it by when a patient feels that they're normal daily activities or their work or their hobbies are impacted by the reduction in vision.
Mm-hmm. Mm-hmm. And just thinking about prevention or delaying, is there anything that people can do that might stop them getting significant cataracts or stop them progressing?
Yes, the $1 million question. It's probably the $1 billion question, because if anyone works out the answer, they're going to be buying their own Caribbean islands. Certainly the drops that came out about 15 or 20 years ago don't work for cataract. I think, unfortunately, it's the same boring, sensible advice, but the universally true advice that a healthy life is invariably helpful for reducing the progression of cataracts. So there's almost no doubt that smoking, again, progresses cataracts. There's almost no doubt that not being overweight and having a healthy diet and exercise helps retard the development of cataracts. But it's, these are things you've got to do over decades, but that's the point of healthy living and well-being. So it's
What about one common one I think that people ask about is sunglasses? What about wearing sunglasses, and what does that do to our eyes?
So we really, I keep saying we don't know. It's because I'm so evidence-based. That's the point of, I guess, doing research, is you start to realize how little you know rather than how much you know. We really don't know. So sunglasses are interesting because cataracts come on at a much earlier stage in Africa and other developing world settings, and the jury's still out about whether that's from much more sun exposure in most of these places, or is it from poor diet, particularly in an early stage, or poor health and illness and other exposure to things like malaria. So we don't know. I think it's quite likely that excessive UV light exposure is not good for your lens, certainly not good for your skin or any other bit of your body. So it would seem highly likely that it's not good for your lens. So I think it would seem a risk-free bit of advice to say, keep your sunglasses on in sunny conditions, and not least because a whole other topic of mine, which we can talk about on another podcast, is cancers of the face. And eyelid cancers, so eyelid basal cell carcinomas, squamous cell carcinomas, melanomas are prevalent, increasingly prevalent with our sun exposure, and sunglasses will certainly reduce the risk of that. So it's the standard Australian advice of sunglasses, hat and sun cream.
Thank you. Thanks. Now, when you're doing cataract surgery, there's a whole host of options in terms of the prosthesis, isn't there? There's a whole nother science now, isn't there? Talk us through
and it really depends who you ask what the right advice is, but I'll give the sort of straightforward answer first. So the first thing to understand is what cataract surgery is. So cataract is obviously the lens. You need to imagine the cataract being a little bit like a Smartie. Okay. So it's got an outside case, which is called the capsule. It's obviously not pink or orange, it's transparent. And then it's got inside substance. So you can imagine like being the chocolate of a Smartie. And the point of cataract surgery is to cut or tear a neat circular hole in the front of the Smartie or the lens. So the front of the capsule, take out all of the opaque or cloudy stuff. So take out all the chocolate, so to speak. And then you have a remaining capsule with a circle cut out of the front, so an envelope that you can then put the lens in. And the reason you need to put a lens back in is you still need to focus light because you've just taken out the object that does all the light focusing. What lens you put in is the choice between patient and surgeon. And generally you would aim, most patients would say, well, I'd like to have clear distance vision. That's what I used to have, and that's what I'd like to have again. So I'll have a lens that gives me clear distance vision. And that is the simplest, most predictable, safest strategy. And frankly, that's what's done almost always, both NHS and privately. And there's not a huge difference for most of us. Well, in fact, there's no difference for many of us, NHS and privately, what we'd do. So you'd aim for clear distance vision and you'd say, I think you have a very high chance of having clear distance vision, but you will, of course, need reading glasses. And most patients will say, well, yes, I started wearing reading glasses at the age of 48 and I've always worn them and it's not a great problem. And reading glasses will typically be the sorts of ones you can buy off the counter, over the counter, but you might have one better pair from your optician for when you read for longer periods of time. So that's simple. Then there'll be groups of patients who have always had near vision. So they've always had glasses since they were teenagers. I'm certainly one of them. And they might say, well, actually, I've always read without glasses and put glasses on for the distance. So I'll stick with that. And again, you can do that with your choice of lens. So that's quite a straightforward situation. It gets a bit more complicated when people want to avoid glasses completely, which is a very reasonable desire, but we don't have a perfect solution. And there are two ways, which I won't bore you too much with, but of doing that. You either make one eye for distance and one eye for near. Works brilliantly for people who happen to have been born with two different prescriptions in their eyes. So there's a proportion of people, a few percent of the population, happen to have a distance eye and a near eye. Has huge benefits because they're the only people who don't ever need reading glasses. Has downsides because they never actually are focusing with both eyes at the same time, but they don't know that because that's the way they've always been. So they're straightforward. There was a phase about 15 years ago when people were where this was being introduced to patients with cataract surgery. So it's called monovision, one near, one distance. But actually a lot of patients don't like it being introduced in later life. They find it just too visually perplexing. So on the whole, when I do cataract surgery, I tend not to introduce monovision as a new thing for someone, but if they have it or they desire it, then so we'll explore it. And then the final thing is what called multifocal lenses. They've been slightly erroneously given the name premium lenses because it makes them sound like they're better. They're not better, they're different. And multifocal lenses give you distance, middle and near vision in one lens, which sounds like the Holy Grail. It sounds like all our Christmases have come at once. The reality is there's never a Holy Grail in medicine, and they have pros and cons. And so the pro is that if they work well, then you probably won't need glasses because you'll get all distances. But the downside is some people will get glare from them because you're essentially looking through the equivalent of a pair of varifocal glasses in the eye. So some people get strange glare from the different prescriptions in the lens. Some people don't get on particularly well with them, so they don't find their distance vision is quite as sharp as they think it should be, or similarly, their near vision. And some people still end up needing glasses because it's not quite precise enough. And so the data on what proportion of people get on well with them is a bit hazy. There's been lots of studies, but it's quite variable. But probably 90% or so of people get on very well with them, which is good. But the 10%, maybe 5% who don't like them are deeply unhappy. And it's not just like varifocal glasses where you can just go back to your optician and take them off and say, I don't get on well with these. This is now a lens in your eye, and it's certainly problematic and carries significant risk to change it. So all of us really still have mixed feelings about these lenses, and we wait for things to develop.
Thank you. That's really cleared up some confusion for me, hopefully for others too. So let's move on to everyday eye health and vision preservation. We've touched on it a little bit, but I think there's a lot more to say, especially in this era where we're all using digital devices. And there's I remember when we had a 14-inch television at home, and my parents would say, don't stand too close to it. And now we've got these huge screens that are right up to our noses. What's the story there?
Yeah, well, I mean, it's funny, isn't it? So, I mean, I guess our eyes have evolved over time to probably our eyes evolved to live in a cave and then go out hunting and then maybe sit by a fire while we cooked whatever we had just caught. And so they had to deal with some smoky stuff, and they had to deal with some wind and some rain and not much else. And then all of a sudden we are putting our eyes through endless screens, huge screens at work, screens on aeroplanes, the aeroplane environments, air conditioning, office environments. I mean, it's quite, I don't think we've given them that much time to change their function. They've had millions and millions of years to evolve, and then they've had 50 years to work out how to deal with our screen life. And I think we suffer in some ways as a result, and many people will comment on their eyes being tired or dry towards the end of the day. And it's no doubt because we've been staring at a screen all day, and then we get home and we continue to stare at a screen. And we are certainly, for my teenage daughters, they're not going out to the park to play football like we did. They're back home and on a screen. So, and there are things you can do to try and help it, but it's a tough gig for the eyes, I think, in the modern world. So in terms of helping it, it's really quite, I guess, boring, simple strategies, but they are quite effective. So a few things. I don't know if you know the 20-20-20 rule that's sometimes broader. If you're looking at a screen, and this is a kind of work thing, then every 20 minutes you need to look at something 20 feet away for at least 20 seconds. That's it's a bit of an Americanization, but it's quite a good strategy to think. And I don't think many of us do that. I think once we're focused on a screen, we are there for a lot longer than 20 minutes. And I think, one way you do it is you get up and you have a walk around, although it's probably not sensible to go out for a cigarette as your break. Over and above that, there's an increasing focus on blinking. There's some beautiful, really elegant studies showing how little we blink when we're staring at a screen, and our blink rate reduces, and even the quality of the blink may reduce. So people are being encouraged to consciously blink. It's quite a difficult thing to do, to have a little break you've just done it now. So it's quite a difficult thing to do, to force yourself to blink. But I think you can start to just introduce it as a semi-conscious, semi-subconscious thing. A very innovative, I think Israeli startups just developed glasses that have a tiny little electrical pulse that makes you blink, and it's connected to I think it even connects to a smartphone, a smartwatch, and monitors your blink and actually makes you blink when you don't. So that may be the future. So, and the reason for blinking is when you blink, you spread your tears around and you probably aid the production of more tears. You almost squeeze out more tears. So that's critical. Similarly, eye drops again. So artificial tear or dry eye drops, it's the same thing. There's 1,000,001 different ones. I can't tell you which ones are better or worse, but I would, you try and work out which ones you like best. Difficult thing to change, but certainly there are issues with air quality in office, and particularly in office environments, old air conditioning infrastructure. I see a lot of patients who report that their eyes are significantly worse in the office environment, and as soon as they go out, they improve. So whether you can change the air conditioning in your office is another question, but certainly opening windows. Some people use a humidifier to improve the water content in the air. And then if you're really desperate, there are moisture retaining glasses. So they don't look like swimming goggles, but they do have a little protective side shield to keep humidity around your eyes, and you can get them. They don't have to be sunglasses, so they can be quite helpful. So.
Sure. Thank you. So just to understand now, why does it matter if your eyes get a bit dry?
Yes, it's a really good question. I think so our cornea is the clear window in our eye. So it's a beautifully designed structure. I mean, this human tissue that stays utterly clear for your whole life. And it's so clear so going off a tangent, but corneal transplants is taking a cornea from someone deceased and using it to replace a cornea. And it's the only transplant you can do where you can take a cornea from a deceased person who may be 70 or 80 years old and use it in a young person, because it's got so much longevity, this clear structure. And clearly you couldn't take a heart or a kidney from a 70 or 80-year-old and use it in someone. So the cornea is this amazing structure, this completely transparent structure. But one of the things it depends on is having a moist surface at all times. And the way that moisture is retained is complicated, but essentially it's tears, which is a mixture of oil and water produced by glands around your eyes. And it's windscreen wipers, which is your eyelids continually opening and closing to spread those tears around, and a drainage system that allows the tears to drain away into the back of your nose and throat. And if any of those things go slightly awry, the whole system falls apart. And ultimately your cornea, that depends on having this perfectly moist surface, but not too moist, so you're not looking through a swimming pool, will start to suffer. Now, it might just suffer in a non-permanent way, that the clarity of the vision is not so good, a bit like a car windscreen with slightly smeary water on it. Or it might suffer in a permanent way where you start to get scratches and scars and other things from chronic dryness or chronic failure of that moisture on the surface. So everything about looking after the ocular surface, the surface of the eye health, is about how do we maintain that tear film. So lid function, eyelid function, tear production, tear spreading over the eye, and then tear drainage.
Thank you. Thanks. Hopefully that motivates people to do the things that you've just said about, I guess, blinking, limiting your time, getting drops if you do have dry eyes. Don't ignore it.
Yeah, absolutely. Yeah.
Great. So I've been listening to try and think, so what's the take-home message here? And we've covered a real range of things. It comes down, I'm second-guessing you, to some of the basics again, doesn't it?
It does. I mean, eye surgery is this funny mix where some of the stuff is extraordinarily high-tech and complex. And if anyone's ever spent time in an eye clinic or even an optician's practice, you see amazing technology and gadgets. And we do, some of the surgery is, even cataract surgery, which we do so often, is this very, very finely tuned microscopic surgery using an ultrasound probe to break up a lens and then a tiny little aspirator or vacuum cleaner to suck it out. And then some of the bigger surgery we do, some of the stuff I I do is endoscopic, so camera surgery up the nose to reach the back of the eye socket, really high tech and extraordinary stuff that was, beyond people's wildest imagination 50 years ago. And yet the other big chunk of eye surgery is really simple, sensible health promotional messages. And it is the same, it comes back to the same things about looking after your general health is so critical for your eyes. So, obviously stopping smoking, or not starting smoking would be even more sensible. But also, diet, exercise, eye health, so moisture on your eyes, probably some supplementation, certainly with vitamin D, possibly selenium in some situations. So it's all the sensible health promotion messages in conjunction with this very, very high-tech specialty.
And getting your eyes checked?
Yeah, so the general advice, and I think it's very sensible, is to see an optometrist once every year. Optometrists are really good at both. I mean, we're incredibly fortunate as eye surgeons to have optometrists, because obviously they do all the glasses prescribing, which embarrassingly most ophthalmologists are now terrible at. In generations gone by, we used to be able to do it. We do it for all our exams, and then we start to forget how to do it. So that's the stock part of ophthalmology. But the bit that probably doesn't get the recognition it deserves is that they're really good at spotting eye health problems. So they're almost invariably the people who spot glaucoma and will then refer on to an ophthalmologist or an eye clinic. They're almost invariably the people who have the preliminary discussions with patients about cataracts. They often spot eyelid lumps or bumps and raise the question as to whether they are skin cancers that will need attention. Even the more kind of cosmetic things, if they're trying to do an eye check and someone's eyelid skin is drooping in the way, they will say this is quite tricky to do your check, and you might want to just have that bit of that droopy eyelid addressed. So they are a vital part of the whole process, and we're utterly dependent. And then when we've seen patients, we invariably say, you need to go back and see your optometrist for your new glasses after cataract surgery or your yearly check. So that I'd say a yearly check is probably a good starting point, and a bit more frequently if you're running into problems, and a bit less frequently if you're young and healthy.
And I guess if people think they've got eye problems, they can go to their optometrist or GP. And I think probably if someone's got a headache, do you think?
Yeah, absolutely. I mean, eyes connect to pretty much every part of the body, and they obviously connect to the head. So headaches, as a GP, you probably know, it's the sort of nightmare scenarios that it's so common, and we don't quite know whether it's going to, whether it's the 1 in 100 that represents something. And similarly, when we see people with headaches and some visual symptoms in eye clinics, it's problematic. And do we scan or don't we scan? And should we be scanning everyone on all those tricky health questions? But one huge benefit of looking in the eyes is if people have got significant headaches and chronic headaches, we can look for something called papilledema. And what papilledema means is swelling of the nerve that we mentioned earlier at the back of the eye. And if that nerve is swollen, it likely represents something going on behind it, some sort of pressure from something in the head, and obviously would then necessitate an urgent scan. If that nerve is not swollen, it doesn't say that nothing's going on, but it's certainly a very reassuring sign. And so we're not really in a position to look at in the eyes of every single person who's just started to have a headache, and there'll be other signs and symptoms that might make you think this headache's a bit more suspicious. But it's certainly an important part of headache management is checking for this thing called papilledema.
Thank you. And I certainly find it's very hard to get a good look at the back of the eye without dilating the pupil, isn't it? I think, but optometrists seem to do. Yeah,
I mean, I think we've been really unfair on GPs because we teach them all to use, as you know, this thing called an ophthalmoscope, which is this tool that's been around for 80 years. You have to kind of get very, very close to the patient and look through one eye, and you have to get the focusing just right, and then you only see a tiny part of the back of the eye. And we teach medical students to use it. And of course, in eye clinics, none of us ever use an ophthalmoscope. I haven't used one for about 15 years, I don't think, because we've got different machines that give you much better views. And what we get is what's called a binocular view. So you almost get a sort of 3-dimensional view because you're looking with both eyes at the same time. And not only do we teach you to use this antiquated equipment that we don't use, you only really probably need to use it every few weeks or few months, which is not great for any skill set. So I think the reality is that most GPs are going to quite understandably say, probably you need to get a check by an optometrist because they are very good at looking at the back of eyes. And if there's anything that raises concern, and there are various red flags that will raise concern, you're going to need to go to an eye clinic or an eye casualty to be checked.
Thank you. Last time I spoke with Celine Woodthorpe, who helps families and children with their oral health. And so she had a very specific question for you, which is, when should you take your child for the very first eye check? And is there any link between behavioural challenges in children and eyesight problems?
So it's a very good question, which is normally what people say when they don't quite know the answer. The first thing to declare is that children's ophthalmology or children's vision checking is definitely not my area of expertise. It's a big public health thing. So I'm going to have a go at answering, and I can imagine there'll be probably lots of listeners going, no, that's not correct. But I did do a little bit of Googling just to make sure. So I think the steps that are taken, so within 72 hours of birth, children's eye checks or children's health checks, babies' health checks are done on the ward or done as soon as a child is born, and an eye part, something called the red reflex, to see that there's a red light coming back from a light, is done. So that picks up the very first potential problems of very serious stuff like neonatal cataracts. And then there should be some sort of physical exam done by a GP or a health visitor. I think it's 6 to 8 weeks, which again involves some sort of eye check. And then it then starts to get a little hazier. There used to be I remember there used to be a universal screening program for school kids. That is now more patchy and is a bit postcode lottery-ish, where some schools will have a proper vision screening check at the start of school, so age 4 to 5, and some postcodes or areas or schools won't, and they depend on the parents to do that. And I'm not sure how well the public is advised as to whether their school does or doesn't do vision checks, and also what happens if your kid happens to miss the day in a school that doesn't. There's another problem, which again, slightly more detailed, but one of the reasons you do checks is to check for a lazy eye, an eye that's not developing its vision, or medical terms, amblyopia. And ideally you want to find amblyopia a bit earlier, because that's when you start patching. And patching, as much as it sounds like a very basic therapy, is unbelievably effective at making the failing eye develop normally. So you patch the good eye in order to encourage the bad eye to see. And 4 to 5 is probably a bit late to start patching. So the onus is again a bit more on the parents than maybe that's appropriate, that we're responsible for our own health and our children's health, but it may not be enough guidance. And I guess the only advice I've got in an area that's definitely not my field of expertise is, as parents, we probably have to look out for any signs that our kids' vision is not developing as we should. They should be grasping at things. They should be able to, you could probably gently just wave your hand in front of one eye and then the other eye and see if they're still happy doing whatever activity they're doing, invariably coming full circle, probably looking at a screen with both eyes. If they are, and they're grasping at things and they're seeing things and they're picking up small objects, then their vision is probably developing. If they're not, or you're not sure, then certainly worth checking. And in areas where you don't have a school screening program, I would say it's pretty sensible to take your child to an optometrist at about 4. They're very happy checking vision at that early stage. There is an interesting thing that's happened. Sorry, I'll just bore you for one more second. There's an interesting thing that's happened in the last sort of 10 years, which is when we do the red reflex check at any age, we're looking for a lack of a red reflex, a lack of this bright red. As you probably know from when you take photos, old-fashioned photos, you see the red eye. And the red eye is actually a good sign because it means you've got a reflection from the retina. That's what gives you that red. But strangely, there was, with smartphones, you quite often get a white reflex, not a red reflex. And we had a phase of what was called the iPhone cataract, which was not a cataract at all. It was just people understandably worrying when they took a photo of their child and they got this white reflex and Googled the white reflex. Obviously, when you Google, it's either a cataract or a cancer inside the eye and quite rightly coming rushing into hospital. And then if you just change the angle of the light, you get a red reflex and you can reassure and they can go home again. So yeah.
That's good to know. Thank you. And did you have any reflections on, or did Google have any reflections on this possible link between behavioural challenges and children with eyesight problems? I'm going to be very honest. It's just outside my area of comfort to say. There's absolutely no doubt that, the simple things that poor or impeded vision at school has a huge correlation with poor learning, poor behaviour, and it is such a common tale. And I see it. I mean, I end up seeing quite a lot of children with eye conditions that they have inadvertently been sitting at the back of the class. They've got naughtier and naughtier because they have not been able to see the board. Someone pulls them to the front of the class
And then they start to see the board and everything gets a bit easier. But it's maybe by that, quite a lot of damage may have been done by then. So absolutely. And that's another reason for the screening program, is how do you keep kids behaving well in a classroom?
And I think that's it too. I mean, looked into it a little bit prior in the sense that if you've got somebody who has behavioural challenges anyway, take away one of their senses, like it's going to be worse, isn't it?
It's a pretty vital sense as well. It's absolutely.
Yeah. And we see it at the other end of the spectrum too, with people with dementia. It's worse if they can't hear or they can't see.
Absolutely. Yeah. I mean, I have to say, just the raising dementia is fascinating. I think some of the most rewarding cataract surgery I've ever done is people with advanced dementia. And some of them can't even read the letter chart, so you don't know what their vision is. You just look in their eyes and you see their cataracts and you think, wow, this is kind of an odd cataract to do. And then behaviourally, they can be completely different after the cataract surgery. So obviously the dementia doesn't go away, but suddenly having that vital sense means they can be functional again. And it's incredibly rewarding, even if it can't be expressed in terms of reading letters on a chart. Their behaviour will change.
That's fascinating for me, because I've occasionally thought, really, is this right? It's going to be very difficult to do. We've got somebody with limited understanding of what's going to happen, the risks, as well as limited life expectancy after, but
they're amazing. And I've had exactly the same thoughts, and you also have the slightly nervous surgeon thoughts of, well, what happens if this individual is not going to lie still during cataract? I've actually done one cataract with the husband holding the hand during the operation, which was incredibly touching. And he said, if I'm there and holding her hand, then she's very likely to lay still, and if I'm not, she will understandably get very nervous and probably start to want to leave the theatre. And so all sorts of arrangements were made for him to come to theatre. It was just wonderful, and again there was an amazing behavioural change afterwards. So it was wonderful. So those are nice moments in cataract surgery.
Fantastic, thank you. I think we'll wrap it up there, because we've talked for quite a long time now, but it's been fascinating to hear your thoughts and feel your passion for what you do. Thank you for spending some time and sharing your wisdom.
Thanks very much, Nick. It's been really enjoyable. Thank you.
You've been listening to the Health and Wellbeing podcast, where today's focus was on eye health with Professor Saul Rajak and me, Dr Nick Harvey. For more information and resources, check out our website sdhc.org.uk. If you have any feedback or suggestions for future episodes, please email us at sdhc.feedback@nhs.net. Join us for our next episode, where Khalid Malik will be coming on to share insights on innovations in hip and knee replacement surgery. Please take a moment to subscribe to help support us in empowering others with their health and well-being.